My name is Sibongile Nkosi, and I am one of the co-executive director of the Global Network of People Living with HIV. And here today, I have my guests, which we are just going to have a conversation around what is happening now with the HIV response. And I think we will just start with looking at where we were really, and what did it look like from a health service delivery for people living with HIV really on the ground. And today we'll be speaking to Dr. Nduku, and you can just start maybe just elaborating more about yourself and your background. And then we also have Kenly, who can also, Kenly has been around also. Both of my guests have been around the HIV response, so they know so much more. And it would be interesting just to hear from you looking at the past and then where we are right now and what do we need to move forward and what is the role of the PLHIV networks in building the new future. Thank you. So Dr. Nduku, I'll start with you. Introduction, a brief one. Where have you been and what have you've done and where are you right now?
Well, thank you very much, and really it's a pleasure to be here. I'm honored. My name is Dr. Nduku Kilonzo, and I am the CEO of an Africa-led, Africa-based consulting firm called Yemaya Health Advisory. I come from the background of HIV public health, having worked in the private sector with an NGO, being the CEO of LVCT Health, pioneering NGO in Kenya, and then moving on to work in government as the chief executive of Kenya's National AIDS Control Council until the end of my 2 terms, just around the COVID period. So I'm just reflecting on the question that you have asked, which is where we are coming from. From a service delivery point of view, first let me start by saying that we have had a system that has had, sort of very dedicated, HIV dedicated supply chains. When I say supply chains, I mean commodities, procurements, how they are managed, how they are tracked, how they are distributed. That has had dedicated data systems, whether it is data collected in facilities, whether it is data about how patients are managed through various electronic medical records. We have also had, and all of this was delivered through NGOs that were funded by PEPFAR and other funders. And perhaps this was one of the reasons why we achieved such scale and progress. However, from the point of view of sustainability, it also created significant challenges. One was multiple systems. Almost every country that I know of had multiple data systems, multiple systems for supply chain management, multiple systems for community services. So you'd have some that are focused on PMTCT with mental mothers, some that are focused on ART, and some that are focused on youth. So, and they were largely overlapping, fragmented, and in parallel to the public health system. So they got us where we needed to get to respond to the HIV, but they were not fit for purpose for where we needed to go or where we need to go now. When we talk sustainability, sustainability is really about the ability to keep going, the versatility and being able to be flexible enough to deal with adversity. So earlier this year, when there was a change of policy with the US government, and that also meant that with the stop work order, there was immediate cessation of all of these systems. All the NGO-run systems literally came to a standstill. It meant that lab systems, healthcare workers that were funded by NGO in many countries ran into the tens of thousands. It meant that data systems suddenly today were operational, tomorrow stop work orders, they have all been shut down. And there has had to be a process of negotiating, reorganizing, but also that has been marked by a separate process of a waiver. When I think about sustainability, then this is what governments have done. And it is important for me to mention that governments and country stakeholders are agencies, and that they were able in this case to reorganize and immediately identify what the priorities were. At that point in time, the priority was ensure that people are not missing treatment. That was the immediate priority. And therefore, pivot all the people living with HIV who were being served by these standalone services into government facilities and through government systems. So when we think about priorities, that was priority number one. But in terms of moving forward, it is the priority that these systems now have this influence of hundreds of thousands of people who need care, chronic care management, and they were not ready for that. So how do we ensure that they are then reorganized, or there is reorganization to accommodate those? There are opportunities, and the opportunities, first of all, lie in ensuring that the supply chain is secured. While we have stocks now, we need to be thinking about stocks not just now and in the next 9 months, but in the next 2, 3, 4, 5 years. What does that recurring planning and ensuring that these testing commodities, testing reagents, test kits are available? And the second is really ensuring that communities, and in this case, I'm talking specifically about networks of people living with HIV, become part of the community health systems in countries, that they then can support treatment, adherence, PMTCT, that is, pregnant women who are supported through mental mother systems. So, I could keep on talking about this for a long time, but, I'll pause there and really ask you how.
Yeah, I'll bring in Kenly, and maybe Kenly, we can just start. It's so important what Dr. Nduku said around support, and has mentioned the different pillars of support that will be required, or the PLHIV networks can actually add as we reimagine the health systems moving forward in countries. And I like what she said around, because currently there's a different, right? So in the global context, there's people who are pushing for the status quo to remain, while saying this is what countries are needing. And I appreciate that you're highlighting that this is not what countries are needed. Countries wanted ownership, because this is also about ownership of the health systems in those countries. And I want to bring you in, Kenly, to just reflect what is the specific, how do you think PLHIV networks can contribute to that support? And what do we mean, what do you think realistically is that support that we can provide moving forward?
Thank you so much, Sibongile.
And maybe start just by introducing yourself. I didn't introduce you.
That's okay. Yes, so my name is Kenly Sikwese. I'm the Executive Director of Afrocab Treatment Access Partnership. It's a regional organization with its secretariat in Lusaka, where I operate from. I have been with the organization since 2011, since its founding. And along the journey, I have been in the privileged position to have been part of many HIV developments that have occurred in the last 15 years, right from when we were moving from treating people late to test and treat, to introducing what we now refer to as differentiated service delivery. I co-chaired the 90-90-90 or 95-95 now targeting process in 2014. And at UNAIDS, and I've been a board member, UNAIDS, UNITAID, at AVAC, and sat on several steering groups. Coming to our point of discussion, I think in a sense, these evolutions of HIV care that I've been part of have given me quite a bit of insight, because in that evolution, there are things we agreed with that have worked, and there's some things we disagreed with at the time, and time has proven us right that they have weakened some of those responses. And just building on to what Dr. Ndungu has been talking about from a PLHIV perspective, one of the that was actually one of the missing pieces. It is one thing to have me and one or two people in the room, but it is another to actually have or give me the opportunity to go back to my constituency and share and get input, so that what those policies or decisions are making reflect the views of the people living with HIV in the countries, so that it's not just my opinion, because I will always have an opinion about something. But what that process meant is that they were, first of all, very highly technical, in the sense that, you had experts in the room, technical experts, whether from a public health perspective or clinical perspective or whatever it was, researcher. And so they sort of carved the conversations from their background and from the perspective in which they saw, the lens in which they saw the HIV response. That meant that it was shaped from that perspective. And the other piece of those processes meant that the countries had very little input. They really only saw things at a very advanced rate, fairly late. And I like what Dr. Ndugu said. So we found ourselves in a situation where the ideas were great, but the actual processes themselves and the solutions were not fit for purpose. They were, serving certain perspectives or, maybe not so much interest, but lenses with which they were, being interpreted, as I said, from the various technical experts. And so from the one thing that we need to change immediately, for instance, when we were thinking about developing differentiated service delivery, our idea was very simple. And I was sharing with colleagues about how simple and stupid they were, that to a person who's been in school for 12 years with a doctorate, it did not make sense that you could actually formulate responses based on a community-based approach that is based in the village, in the township, in the city, and still have the same kind of impact, or even a greater impact, as we have seen today. Now you're having to develop and formulate differentiated service delivery to meet certain contexts. This idea that we had from the beginning was supposed to meet all contexts that could be adapted at, depending on what priorities needed to be met. Is it adherence for that community? Is it testing for that community? Is it treatment for that? Whatever it was. And even if it was multiple services that were required, they could be formulated in that community. And we thought they could be, formulated from, from a bottom-up approach, where we subdivided the communities to the lowest, smallest denominator. For instance, households of 1,000, for instance. And if you had a community health worker that was posted, it's so easy for that household, for that community health worker to visit every household easily, almost every month. And they would know exactly where the children living with HIV were, who were on treatment. They could monitor them. They would have known exactly where every child who had malnutrition challenges, whatever. And, if there were other needs, whether there were NCDs, whether it was a malaria outbreak, you could monitor the health, the health needs of that community at community level. Because the idea was that then they would be attached to a health facility. If it was a sub-level community of 1,000, they would be attached maybe to a rural health community. If it was a district level, they could be attached to, so you could go within the health facilities that were available in those communities. But when we shared this, it was so simple. And guys thought, well, instead of thinking, how can we make it work? Decided, no, I don't think I could get a doctorate from this. So let me rewrite it. So it went to postdoctoral students, and this is what we see. And so it has created so many gaps. And it's just an example. We could see this translated amongst, in different processes, whether it's supply chain. We have very mature supply chain systems. Dr. Ndugu has worked within the health system for a long time, and she could tell you, our supply chain systems are so mature, that all they needed to do was leverage the health system, the supply systems within the country, rather than create new ones, which, as we now know, after January, broke down, which, and so we're not sustainable, and I totally agree. And so we need to now rethink today, how do we now bring this national ownership into reality? How do we now engage people living with HIV at national level, at regional level, at global level, so that we have this bottom-up approach and top-down approach where we're informing, where the whole response is owned by the people affected by the disease, and the whole narrative is determined by them.
And I want to come back to you, Kenly, because what both of you are saying is basically we're going back into countries and country ownership again. And what is interesting to hear from Dr. Nduku is that governments have already wanted this. Yesterday you said this, that the governments actually wanted this. They wanted ownership of the HIV response. And what I'm hearing from Kenly also is that communities had very simplified contextual solutions, even when there was the donor-funded response, you provided simplified solutions to problems. But because, again, I think investment, money can create very complex systems because you have the luxury, right, to play with money. But now I think what I'm hearing from you is that communities might have to actually go back to the original solutions that you had, and that we had as communities, to be able then to also then add more value back into our governments, right? Is that where we should be thinking as communities?
I can see you looking at
both of you. Anyone can take it.
Let me just sort of make two comments. The first, I think, is to say that there is a narrative sometimes that comes up that governments don't have capacity, don't have ability, can get this done. I have always challenged that narrative, and I really want to say that narrative is completely makes no sense, because governments run all other health sector, sort of issues. That's the first thing to say. The second is to say that what happened was we invested significant amounts of money in a parallel system that basically shut down the day the resources were no longer flowing. Now, if we had taken, or if in retrospect, had those resources built the healthcare system, I have had people say those are HIV dollars, they should not build other systems. But if we had done that, we would probably be way off. But right now is not the time to say if and maybe.
Yes.
The time it is right now is to ask ourselves what we need to do. And I think there are a couple of things that, are most important. In the medium term, actually in the short term, is to review and ensure that our supply chain does not end when the current stocks sort of run out, that we are actually starting to plan. Number two is to say that there are opportunities to have buffer, because remember, this has happened when governments are in middles of financial years. And therefore, the resources take a little bit of time to be renegotiated. But there are resources that we have. Global Fund has resources. It's time for governments to say, write to Global Fund formally and say, we want to reprogram the money that we have so that we can ensure that we cover the systems that are most critical for us to be able to move forward the response. The third, I think, priority is really about looking at recognizing that whereas the HIV response has always lived in the public sector. It's because it has been, it's been funded, so most of it was provided for free to the client.
Yes.
But there are people who are living with HIV or who need HIV services, testing and so on, who are able and willing to pay. And that has been demonstrated by some models. LVCP Health in Kenya did a model. They have a functional clinic, willing and able to pay. How do we design models that move those people who are willing and able to pay, whether through their own pocket or through insurance, to the private sector, so that then the private sector, but that also means that in the short term, we must capacitate the private sector, because I don't mean the private sector of the hospitals here in Nairobi. I mean the private sector of the clinics that run at the, community level, village level, county level, ward level. There are clinics there. So why does someone need to have to go to a referral hospital to go and get their medication if they can get their viral load testing at the local clinic and they can get their refill at the local clinic? And those are the things, the systems we must put in place now. We must also use the faith-based facilities for the same thing. The faith-based facilities are also organized in terms of systems, data systems, in terms of coordination for supply chain. How do we leverage those? Those are the things I think that are really important right now as we start to say, at the end of the day, government can get this done, will get this done, because government has a responsibility and is willing and ready to do it. But we must ensure that in future, resources do not crowd out private sector, faith-based organizations, and government leadership and stewardship.
I want to take you to the donors, Dr. Nduku, because I think we know now, as much as, so of course there's the US government who's just reshifted, but there's still like other countries that were still filling the pot. But I think in our conversations, what we are hearing is, has been around, we can't fill the US gap. There's just no way. However, we are still quite interested to continuing to support where countries need. And I heard the short term, particularly with the Global Fund. But if I was a donor and I was funding civil society organizations in countries, and I want to still make a contribution, for instance, in certain countries, particularly, I mean, the Dutch government is still looking at making some investments. But I think the big questions they're having to ask, even Big Pharma, through their foundations, they keep coming to us and asking us, so what should we be funding? What are the key things we should be funding? And I just want to tap into that. What do you think if I was a donor sitting there and wondering, with this now, and as you say, countries are taking back their HIV response, how could donors that are still willing to fund do well, and what should they stop doing moving forward?
You want to take that?
Okay. Yes, then you can bring in the more policy, national level perspective. I think the first thing for me that needs is to go back to drawing board. And that drawing board means, as happened in the 90s before we had treatment, everybody was running to people living with HIV. What shall we do? How shall we, and people living with HIV came up with solutions. Look, people dying, give them some dignity. Let them die in dignity, especially here in our part of the world. And so they formed support groups, they formed, churches came in, and I'm glad you're mentioning churches, and, provided home-based care, and so on. And so this whole HIV response, pre-treatment, was predicated on the level of engagement that the community provided, and completely designed by the community, almost completely designed by the community. So I think we need to go there and fund those processes, meaning the global network, first of all, needs to be a strong network. Collect all the data we need, information, mobilizing communities. What is it that is working, that's not working? And we synthesize that information into a package and be able to provide it for the immediate term. I think this is something that is so urgent because we need to start filling gaps quickly.
I want to challenge you there, Kenly, and I want to challenge you because this is what's coming from donors.
Yes.
We are seeing the response is moving away from the global to the south, to countries, and this is what we are talking about now. And we want to give countries because we are seeing that governments, as we said, government have agency. This is what donors are saying. You global network of people living with HIV, you challenged us. We challenged them, actually. We said to them, you guys are acting like governments don't have agencies. Countries have agencies, so therefore, we actually have to go back to countries. And then they said to us, then what's the point of you guys? You know what I mean? Because the response, back then, yes, because it was an emergency and people, and the Global North is known for having the money. They were able to organize from a Global North perspective. And we know the Global Network is coming from the North. It's either, if you're saying Global Network, are you even challenging us to think of a Global Network from a South? That's what I want to just hear from your side in terms of if I was a donor and you're saying to me the global network, donors don't want to give a global network money anymore. I'm telling you, because they're saying things are moving into countries. So I want to know from, if I sit there as a Dutch government and I'm saying I want to invest in countries, what should I invest in and what should I make sure I prioritize and what should I make sure I don't ever do as a donor moving forward?
I think there are two levels. There are those things that are needed by the countries now, immediately, supporting the supply chain mechanism, filling in gaps for healthcare, workers' pay and salaries, and so on. Those ones, non-negotiable. Those are needed immediately. What I am talking about, going back to the drawing board, is now this sort of midterm input from the community. The problem that what I spoke about earlier on created is that communities were moving at different levels. So you have those that are quite far ahead and advanced, understand we're involved in the health delivery of their countries, can articulate it, and can probably make some level of input. Okay, but what I'm talking about is those countries, especially certain regions where the level of engagement of communities is so minimal, but so necessary and so important. Somebody's got to stand in the gap and be able to. The global network already has the network, so you have this capacity to leverage your position to coordinate a global sort of response, put data together. You need that to be done at a global level. How you disseminate this data, how you use this data to empower the communities at country level, how you engage communities and hold consultations. What is important? What is a priority for your context? And so that is what you can do. It's you're mobilizing. Dr. Nduku used to use a certain word when she was at the National AIDS Council about the role of NAC. I think you have a similar role of this, having the capacity to bring different multi-stakeholders together.
Yes.
But you can do the same for communities. You can bring faith-based communities. So what are they called? International religious leaders, the INARELAs, the PLHIV networks. You can bring together youth networks. You can bring together women's networks. So you have all these different groups, carers of adolescents and children. So you have that capacity. And then once you have that data, that information, it's your duty to now support these networks, come up with indicators, come up with measurable, information systems. And so I think there is an important role that you need to play that can never be ceded to countries. And you can also provide the inter-country learning about what's working and what's not working.
So are you telling the donors they should fund us?
They should fund you. They should fund you and to some extent fund you, but also support the national processes, because that's where the actual work will happen. There's this coordination requirement, but there's also this national level actual interventions where the interventions will have to take place.
So, in our view, first, we need transition stewardship in countries. Who maps out what data we have, what we are missing, what is there, what is not there? Who works with the parliaments to keep them informed about where our challenges are. Who is going to oversee a costing exercise to look at the costs of delivering services through national, sort of systems, whether they're in the private sector or in the public sector or faith-based. Someone has to do that work in order to collect that information and then go and make and negotiate with Treasury. And to do those negotiations with Treasury, you will require your Ministry of Health, but someone has to be doing the legwork around it. Okay? Who is it who is going to ask ourselves, where can we get other resources in this domestic body? Who understands how the public finance management system or the medium-term expenditure framework works? That is the National AIDS Councils or commissions. And so we believe that really this transition, this process of change from this system that we have had to where we are now going to, or where we already are but need to manage a few things while we are at it, needs stewardship. And that stewardship, there is capacity. There are institutions with mandate in countries, and those are NAC. So you've asked me the question of resources. That is a place to put resources to support transition now.
Right.
Secondly, it is also within NACs that you have space for communities and persons living with HIV and then the reality is there will always be tension between communities and government. But even when there is that tension, work always happens. And that tension is natural because communities want something specific to communities. Government is always saying we want to look at the bigger picture of public health. So that tension is natural.
Yes.
The question is how we manage it. It is not making it a point of lack of movement. The other sort of big piece that I think is so important and nobody is really talking about it is we must rethink technical assistance. Technical assistance has always been very north and based. PEPFAR and all these other donors, not just PEPFAR, have invested over the last 20 years, 30 years, invested in capacity. Kenly, you've just given us a whole list of sort of places you have been, responsibilities you have had, functions you have had to deliver. I'm sure, Civil, it's the same with you. I have sat in those spaces. So why is it that we are not able to provide TA to our own government? We have the capacity to provide. So technical assistance mechanisms must be localized moving forward if we are going to actually optimize the resources, the limited resources that we are going to have in the short term and in the medium term. And then I will sort of then say that back to the question of where else should resources go. There are G2G, government-to-government resources. Those, I think, must go to the health system, not to HIV systems, to the health systems that will support HIV. They must go to the supply chain system that will support HIV, not a HIV supply chain, because that's where we are coming from. And we are in this case because we had a HIV supply chain or a HIV data system. So where we are at right now is we must be able to have partners who want to support systems, invest in national systems. And if we work through transition stewardship agencies, we will be actually in a place where we can say, this is actually what the country needs. This is what it doesn't need. And my final point is around community health systems. We need to look at the role that communities and networks of people living with HIV have played at the local level, meaning at the village and at the national level. And then look at the fact that we already have funded national systems, including that have community health workers, community health promoters in different versions and forms. And in each country, review those and say, how do we strengthen HIV within these systems? Whether it is by ensuring that all these mentor mothers and peer educators become part of that system, which would also mean reforming that system to make it friendly to, stigma-free and all of those things. But we need to do that because then whatever happens in future, those systems and those healthcare workers in those systems have resources. Now, I said that was the last point, but I cannot help but talk about healthcare workers. We cannot. The attrition in the health sector overall is significant. And while they only served HIV clients largely, they also served in laboratories that did other work. They may have served only in HIV laboratories, but those laboratories also did work on TB and malaria, and in many cases, NCDs. So all these healthcare workers are suddenly largely not available. A few have come back through the places, through the Weaver. But the system has bled significantly in resources. So the question that is there is, how can we develop a phased approach through which we actually initiate a legally viable pathway for this capacity, maybe not all of it, but the most important, the prioritized of this capacity to be retained in the system. Why do we need a legally viable pathway? Because having been employed by NGOs, they had different terms and conditions. They had different, pay. They had totally different engagement terms. Now, with that, we all know that every country has a public service commission or agency that determines how people are employed, their terms, their conditions, even the recruitment processes. These healthcare workers are here. They have these terms, this recruitment process that are not in line with the law. So you can't just say absorb them. Even if a country has money, they will say, how do I legally absorb them without getting into trouble with the Auditor General? Because there isn't the pathway to absorb them. So right now, as you talk about, sort of where is it that partners can come in now? A transition plan where first you identify who are the priority healthcare workers. How do we regularize them? And that means an engagement outside of the Ministry of Health with the Public Service Agency or the Civil Service Agency. And then a process in order for, some sort of update. But also that means that Parliament must be involved, because over time you will need additional resources to pay this additional staff. So what I'm saying is that there is a transition process, even though we have had to do a pivot. For us to keep the system running into the future, we have to go through a transition process, and transition stewardship in country is what is going to get us over the, sort of bridge.
Anything you want to add, Kenly?
Yeah, I'm glad you ending with healthcare workers. I think to some degree, they are some of the most hardest working people who are highly underrated and to some degree highly unappreciated until their service is withdrawn, as is the case. So I think absolutely this pathway is necessary and urgent, and I'm glad Ndugu is talking about engaging Parliament, because I think there might have to be an accelerated process where maybe a legal framework may have to be created through Parliament on how quickly some countries may have to absorb, because you're talking about huge numbers. It's not a few people, So I totally agree, and for me, they are our biggest ally, and I think going into the future, those are some of the relationships we need to manage better so that we move in tandem and in harmony, rather than every time having this acrimony about the source, them being the source of stigma towards people living with HIV or mistreatment and those types of things. I think that moving forward, that's an important role that the global network could formulate. Some process of bridging the relationships between, because I've been a patient abroad, and some of the best nursing care, the best medical care I got were from healthcare workers. Some are still friends because of the professional way they handled me. Even if it was for a short period of time. Why can't we have it in our own countries? So totally.
I have a last question, and then we end. Or do you wanted to say something?
I just wanted to have an addition, and the addition is that as we have these conversations, one of the things that I think networks of people living with HIV would be very useful in is convening dialogues at local level.
Yeah.
To be able to get communities, the community health workers, those that have been laid off, that are really suddenly without, sort of a means of living, and plus now the overworked healthcare. How do we create dialogues that allow that this transition does not become more painful?
Yes.
It is. And I think that could be a role that, the networks could play at the very grassroots levels.
Yeah.
But also they could play at the global levels.
Yeah.
Because right now, as we are having these conversations, I still feel that we are not on the same page.
Yeah.
Still people, or, you get the sense that people still feel we should still be where we used to be.
Yeah.
That countries are not moving, they don't have agency, they can't get anything done, or that we have, we are going to see challenges. And yes, we could, if we don't act now.
Yeah.
But we do have an opportunity to act now.
Yeah. I'm going to bring in the social barriers conversation just as a last point, because I think it's such an important, I think the biggest, obviously the focus has been around how do we maintain treatment, how do we make sure people are on treatment, but I think there's other key players who are focusing on social barriers, right, around stigma, which I think as GNP+, we see it as part of delivering care to people. But I think there's also other social barriers around the legal laws, the laws for the key populations. And that work, I think that's also part of why there's also been that push to also maybe just still maintain some of that funding, because that was where the money was coming from. But now I think the big issue is around, are our governments open to the conversation around social barriers, particularly looking at issues around key populations? I don't know, do you want to maybe say one comment or two comments on that, on how do you see it? Do you see it, and I like what you said around if there's an organizing of community dialogues, then the integration around human rights, around access to care, access to services, could be a conversation together. And prevention, we have not even spoken about prevention.
I wanted to really take 10 minutes, okay, not 10 minutes, but
and maybe that could be another conversation that we have around prevention, because it's really, really important. But I think right now, everybody's looking at how do we make sure that we secure treatment and we, as people living with HIV, stay alive. For now, that's the biggest priority. But we do have to have a conversation around prevention. We do have to have a conversation around the social barriers, because in the meeting, I was in the room and there was just the sense of how are we going to do our human rights work? That was a big barrier in how do we access healthcare. Anyone wants to take it?
No, please. Yes, you're the policy maker.
No.
Well, used to be.
Exactly.
And what is more realistic, really? What should we actually be thinking, really? Yeah.
So, I think I would like to separate two conversations here. There's the conversation around equitable, safe, dignified service delivery. And the legal environment.
Yes.
They can't be totally separated, but in this conversation, I would like to separate them
Good.
for two reasons. I think about my country, Kenya. We have continued to provide services in generally an environment that has been an enabling environment to key populations over the last few years, even though our laws have not changed. So the question is, how has that been possible, and what within that do we leverage?
Perfect.
And how
Yes.
do we ensure
I
that
agree.
we don't lose that? Because I feel that it is easy for us to start saying, we need laws to change, we need laws to change. And we forget that we made a lot of gains even when laws are not changed. So I think it is important to say that. The second point for me, which is really critical, is about, thinking beyond the health sector for HIV prevention. And the people who are on treatment, we want them to be virally suppressed for prevention.
Yes.
But we know that there are those who are unaware, those who are not adhering, those who are not virally suppressed, and all of that means that new transmissions are still going to happen. So on the acquisition side then, we are asking ourselves, if I am well, I am young, I am well, I am middle-aged, I am well, what am I going to a hospital to do? Or a health facility? To go and get medication for what? What am I going to do to a facility, however friendly it is still a hospital or a healthcare facility. What am I going there to do? That is not where we find people who need prevention. We have to go to the Ministry of Social Services and find young people. We have to go to the Ministry of Transport and find all these young boarders who are young sexually active men. We have to go to the Ministry of ICT and figure out how we engage online, because the three of us here have no clue. And, we need young people to be talking to each other.
Yeah.
The point I'm making here is we have lost, and I go back to what you said about narrative and about who is speaking. We lost our multi-sector engagements, our multi-sector strategies, which is where we started. And those are what we need for prevention. Prevention, the healthcare sector is not architectured for prevention. It is architectured for treatment and for reaching out to people who have health issues, even if they are not sick. I'm pregnant, I'm not sick, but there's a health issue. I will get in touch with the health sector. But I am one. No issue.
No. That's so true.
Just for good measure, I'm young. Find me in the sports ministry. There you will find me.
Absolutely.
Find me in the education ministry. There you will find me, even if it is vocational education. And that's where we should be taking prevention. So we must get back to multi-sector platforms of action. So, Kenly.
Yeah, I absolutely agree. And, I think what the last couple of years has created is a scenario where I remember saying this to some colleagues. I said, this idea of banging our government heads, that somehow they're acting as a barrier to accessing services. I think somewhat we might have overplayed that card to draw attention to some of the genuine human rights violations. But to the extent that I think they were blown, might have been a bit disingenuous in my view. It may not be a very popular thing to say, but it is the truth. So what I would like to see in ensuring that we safeguard the rights of all populations, key populations, young people having access to sexual and health services, all these groups that are really on that sort of brink of being excluded is, again, going back to my original story of seeding those decisions and those engagements and those discussions at the community level. Because they can design how to best deliver those services to their peers, to their colleagues. Even I always say, even just out of half of the things we do out of altruism. If my friend doesn't have pills, they're running out of tablets, and they're in another town or in another country. We go to the facilities, pick up. What I'm trying to say is basically let's try and give this responsibility back to the communities, and fund those community services, make them viable. Because I think if we can do that and strengthen, epidemics and pandemics are going to continue coming. And we need to start creating services or systems that can absorb these challenges. And for me, leveraging HIV is probably our biggest, opportunity, and we should just ride on it and use it. We've lost so many years, in my view, because as I keep on saying, if we had started in 2014, as when DSD services was mooted, it would have been a very mature process, and COVID might have been better managed if we had had that mechanism established in the community for providing services, for testing, for vaccine delivery, information sharing, addressing misconceptions, all these challenges that came with the pandemic. We could have been better prepared for them.
Great. Yeah, you've given me so much to really reflect on and to really think about. But I think there's just so much to consider. I just want to think about also people, our viewers, to just say, if in this whole conversation that we had, what are the one thing you want you want people to remember from this conversation? If there's one thing at the end to be like, what is the one thing for this moment that we need to remember? This moment. As everybody's thinking about crisis, because the way it's framed for the public, it's crisis, right? So just one.
I think maybe I could start. I would say, communities supporting national systems is a very viable option, whether in an emergency or in routine care. Yeah.
I would say that let's build more trust with each other. The countries we have and we live in are ours. And the systems may not be as strong as we want them to be. Let's become part of the building of strong systems. Because I still feel like we still bash that the systems are not as good and now have to wait in lines, and let's take a moment and say, how do I be the change that I want to see? And maybe you'll just allow me to say that as we advance the HIV Leadership Forum, which is the Director General's forum, which I don't speak on behalf of, I support, but I can convey the thinking that is going on there because those are government agencies. Just to say that we are really rethinking and focusing on prevention, and we have a lot of information, whether it is on how communities can access social contracting mechanisms, whether it is on multi-sector engagement, and so on and so forth, on the Global HIV Prevention Coalition website, which is where the multi-sector forum is housed. And I think that's just information. Sorry, I forgot.
No, that's really, really important to hear, that the prevention agenda is not being forgotten, because where we are in the global north, it looks like, prevention, forget about it in countries, and it's actually affirming and great to hear that.
We just have to go back to basics.
Thank you.
We have to go back to talking condoms and
Yeah.
in the facilities, not in the facilities, in throughout other sectors.
Yeah.
We have to go to reaching young people. Now I've gone back to the conversation that we just finished. So my one thing, let's build more trust. Let's trust. Let us be the change that we want to see. And let's all get around a table and be able to speak to each other. Thank you.
Yeah.
Great.
And if I may add on this prevention piece, I think we've got to take it to get it out. Again, get it out from the health service. Take it to community. Take it to private sector. Whether we're and including changing a lot of policies and barriers. We talk about PrEP. What about post-exposure prophylaxis? If a sex worker needs, to prevent herself, does she wait to use, does she have to use PrEP? And that adherence for sex workers is usually low on PrEP. What about post-exposure prophylaxis, access to post-exposure prophylaxis? And we know that from studies, they don't have to take it for a month. They can even take it TLD for 2 weeks. I will do the job. So we got to really take prevention out of that box that we've limited it in, and liberalize it so that people have options. We will probably have a better chance at winning in prevention.
Great. I really tried to squeeze in so many things in this conversation.
So sorry.
But no. Yeah. This was really, really great. I think it was really important. And I think for our communities, this is such a really enriching discussion. And even for our donors, I think right now everybody's looking at where do we go? And Dr. Nduku, and thank you, Dr. Nduku, and thank you, Kenly, for really providing us with really important things to take forward. And these was really powerful solutions. So really, thank you. Thank you.
It was our pleasure.
Thank you.
Yes, thank you. Absolutely.
For giving us this opportunity.